It gives you a bit of thought to think we often live in the current and the present and the now and don't spend quite enough time reflecting on what's gone on in the past. Today's talk is really an eponymous lecture for this fellow, William Walker, who was basically a consultant surgeon here in Ninewells. I'll give you a potted history because sometimes it is quite interesting. He was born in Aberdeen in 1925 and then graduated after university in St Andrews in medicine in 1948, so a little bit after the D-Day landings. He then went off to Harrogate, where he met up with his wife, Betty, and then worked with the RAF for 2 years before coming back to Dundee to do training in surgery in around the through the 50s. He then became a senior lecturer in surgery here in Dundee, and then went off to Boston, Massachusetts, where he learnt some skills, particularly in relation to shock and intensive care. After that, he basically set up the open cardiac surgical unit here in Dundee, which was the first place in Scotland to do closed mitral valvotomy and other open cardiac procedures on bypass. So he was very much a forefront leader in his time. As is often the case in Scottish healthcare delivery, the centre of that was moved to the central belt, and therefore he had to find something else to do. So he did. He basically picked up vascular surgery for peripheral arterial disease, set up the vascular lab here in Dundee, which was the first in the UK, and then went on to lead that department through an academic output, and then became a Regis Professor after he retired in 1990. So in a sense, he was very much a flexible but very academically orientated individual. And it really gives my great pleasure to welcome back to Dundee Jonathan Weir-McCall, who will be known to many of us in the audience as somebody who came from London fresh-eyed and bushy-tailed and dressed in a suit. And I think actually we see a very similar sort of appearance today, which is encouraging. Now, Jonathan, I think, arrived under a SCREDS registrar training programme, which we were starting at that point. And he took this bit bull by the horns, both academically and service-orientated, and pushed things along very nicely for 2 years before he went on to do a PhD in pulmonary hypertension and MR imaging, for which he gained a Wellcome Trust funding for that. And after that, he decided to trot off to Canada for a while and spent a year in Vancouver, looking particularly at CT imaging in relation to cardiac work. And then for the last year has been in Cambridge working under Professor Fiona Gilbert, previously from Aberdeen, in relation to Papworth and cardiac imaging. So it's really great pleasure to really welcome what I think is really one of the rising stars of radiology academically across the UK, and the fact that he started some of his training here is a credit really to those in the audience who trained him, which is probably not me. So without further ado, I'd like to welcome Jonathan back to Dundee and look forward to his talk. Thank you.
Oh, thank you very much, Graham. It's a pleasure being back, especially after the flatlands of Cambridge. I was hoping to see lots of hills. The characteristic Scottish weather is currently putting paid to that hope, but one can keep fingers crossed for the weekend. So, amongst the many impressive works that William Walker also did, one of the things that caught my eye, of course, as a radiologist was this pioneering work describing for the first time how the feet look in extreme hypothermia in a patient who'd been hiking in the hills. In the two images on the right, you can see his right and left foot with almost no arterial supply whatsoever. And 3 months later, with conservative management, we can see almost complete resolution of the normal arterial structures, although there's perhaps still a little bit of wasting and narrowing within that right foot. But what's particularly nice about this is it very much exemplifies how we can use imaging both for diagnosis but also for monitoring and follow-up of response to treatment. And we'll touch upon this in the subsequent lecture to come. So whenever we're talking about coronary artery disease and imaging, we're typically talking about atherosclerosis. And there's a common conception that, we evolved, we became Homo sapiens, and we were strapping, fit, out running in the fields. And then modern vices seeped in. We were sedentary, we overate, we smoked and drank. And with these came atherosclerosis. However, atherosclerosis is as old as humans. So they've exhumed mummies from pyramids spanning 4,000 years of human history. And whenever they've scanned the bodies inside the sarcophagi, they have found atherosclerosis in all of them. This is a nice example of left anterior descending coronary calcification, indicative of coronary artery disease in this ancient pharaoh. And not only is atherosclerosis as old as humans have been, it joins us from very early on in life. This is a 14-year-old's coronary arteries. They died in a car crash. And these little black specks that we see here are the early fatty depositions within the walls of the coronary artery. And it's these fatty streaks that will slowly progress and become plaques and narrowings. And in fact, in a study of almost 3,000 subjects in the US, they showed that across the entire spectrum from 15 to 20 through to 30 to 35, we see an increasing prevalence of these fatty streaks. And as would be expected, it follows about a decade behind, but we move on to raised lesions and plaques. And as a man who's already beyond the upper age limit of this, this already inspires me with a bit of nervousness. So how do we start to image this coronary artery disease? Got a whole range of imaging modalities, from invasive catheter angiography, intravascular ultrasound, where we pass little ultrasound probes within the vessels themselves to get a better look at the wall, or we can do CT or MRI. And the invasive measures are the only way that we see this very early intimal xanthoma. But looking at the rest of the coronary atherosclerotic life cycle, we can see that CT allows us to see the earliest stage before we start to see the narrowings on invasive coronary angiography. And the purpose of trying to detect the disease here is to stop us hitting this phase of a thin fibrous atheromatous plaque, which then erodes and ruptures, either leading to healing or thrombosis with myocardial infarction, or it progresses onwards to stenosis and starts causing angina. And for the rest of the talk, we're going to focus on this, and we're going to consider atherosclerosis as the overarching concept of this slowly progressive disease, but also look at the consequences of the plaque and the morphology of the plaque in terms of what connotes high risk, what's ischemic, and what's stenotic. And one of the reasons that we do this is cardiovascular disease is a leading cause of death in the developed world, and by 2020, it will be the leading cause of death in the developing world too. And this, in a perverse way, is actually a good thing. It shows how well we're treating infectious disease and preventable causes in the developing world, allowing them to now live long enough to adopt the vices of the Western world and start smoking and drinking and overeating like the rest of us. Now, while this sounds all to be a doom and gloom, there have been fantastic progressions in our treatment of cardiovascular disease, with a 75% reduction in cardiovascular mortality over the last 40 years. And this is primarily due to the effects of aggressive primary preventative therapies. And I remember as a second-year med student, my next-door neighbour's dad was a GP, and he came in brandishing this version of the BMJ, pronouncing that soon cardiothoracic surgeons and interventional cardiologists were going to be redundant and a thing of the past. Like all such absolutist statements, this hasn't quite come to pass, but we are seeing huge progression through this. We're yet to see a mini pill truly come into impact, although we still see editorials in the Lancet every so often promising that it's just around the corner. So whenever we consider CT coronary imaging, and as physicians, whenever we're considering imaging in general, Hippocrates tells us that we want to, as good physicians, be able to declare the past, diagnose the present, and foretell the future. So can we actually help the day-to-day practicing physician do this? And I'm going to start focusing on declaring the past and foretelling the future, because these are intrinsically linked and also perversely far easier than diagnosing the present. And the way we do this is by looking at atherosclerosis. And in fact, if you have a normal CT coronary angiogram that effectively excludes both obstructive disease and non-obstructive disease, if you have a normal one, you are almost bulletproof, at least from a cardiovascular point of view. You have an annualized event rate of 0.04% per year if you have a normal CT. And it's not just the obstructive disease. We can start to see in this green line here, which is non-obstructive coronary artery disease, which is just mild 10 to 30% stenosis. You can already start to see the impact that has on survival, and once you hit the truly stenotic plaque, how much worse you do. And patients without plaque may also not gain the same benefit from preventative therapies as patients with plaque. And we've got these lines on this Kaplan-Meier, survival plot, and the dashed lines indicate those who are not on statin, and the solid lines indicate those who are. And in those who have a coronary artery calcium score more than 0, which means that we're seeing atherosclerosis on their CT scan, there's a marked survival benefit between the two groups from being on statins. However, you couldn't fit a piece of paper between the two lines of those who don't have any coronary artery calcification in terms of the impact of statins. And this is a dose response as well in terms of the severity of your calcification, in that if you have a calcium score more than 100, which is moderate to severe calcification, you have roughly a number needed to treat of 12 for taking statins. Whereas if you have between 1 and 100, you need to treat 100 people, and once you hit 0, you're hitting an almost infinitesimally large number to be able to prevent cardiovascular mortality. But can we do better? Well, we can start to look at what is called high-risk plaque. And high-risk plaque is this combination of positive remodeling, where the walls of the blood vessel have had to expand out in a Glycovian remodeling fashion to try and preserve the inner lumen of the vessel, to preserve blood flow to the distal myocardium. But it does mean that you've then got a huge volume of plaque just sitting waiting to cause damage. If it's filled with fat in the centre, or if there's spotty calcification, which indicates microhemorrhage or neovascularization, these all connote increased risk. And indeed, if we look at the difference between plaques without these features and plaques with these features, we can see an almost 20-fold increased risk of downstream events in people who do have high-risk plaques. The only counterpoint to this is these high-risk plaques are about 1/20th as common as the high-risk plaques. So whenever we look at the absolute number of events, they still come out exactly the same between the two types of plaque. But nonetheless, we can start to look at lesions and start to consider what is the downstream implications of treating them or leaving them as they are. And not just the plaque characteristics, but how the plaque behaves over time is further additive to our ability to predict the future. And if you have a abnormal vessel, but it's nice normal lumen here, and you can see lots of calcification around the edges of the blood vessel there, and you come back several years later and you've seen this marked progression, you have a 33-fold risk of subsequent downstream cardiovascular events. And in fact, this is a greater risk for downstream cardiovascular events than a history of a prior actual myocardial infarction, which only connotes an 8-fold risk of downstream events. So a really powerful marker of risk. So hopefully I've convinced you that there's a combination of using CTA to rule out coronary artery disease and looking at the stenosis and high-risk plaque and plaque progression, we can both declare the past and foretell the future. But now to focus on diagnosing the present, the arguably harder tool. And if we consider how we currently diagnose the present, the traditional chest pain pathway is that someone will come in with chest pain, we'll take a good history, we'll take some bloods, we'll do a resting ECG, and based on their pre-test likelihood that we calculate from this, we'll then decide whether they need nothing further or whether we send them on for some form of stress test, whether that's an exercise ECG, a SPECT scan or an MRI, to determine whether there is any ischemia within the myocardium. And then, based on this, decide whether we need to send them on to the invasive cath lab for stenting or workup for surgery. But does this traditional pathway actually work? If we look at the risk calculators that we use, which we base on how the typicality of the chest pain, split them by gender and also by age, we consider less than 10% to be such a low risk that no further workup is required, and greater than 90% to be such high risk of coronary artery disease that the diagnosis is already made. You don't need to work them up, you can just start treating them because it's assumed. However, unless you're a woman with non-anginal chest pain, or an 80-year-old man with typical angina, you fall into this intermediate category. So what are we really achieving through this pre-test stratification? And the other problem with this pre-test stratification was designed back in the 60s. And if we look in this particular study of 14,000 CT coronary angiograms, the predicted prevalence of coronary artery disease using this calculation was 51%, but only 18% of the population actually had obstructive coronary artery disease. So we've got a 3-fold overestimation of the prevalence of coronary artery disease, and this is far worse in women than it is in men. looking at the next step, we refer them on for these stress tests. And if we look over the last 20 years, we've seen a decrease of the abnormal stress tests from almost 45% to 10% in the most recent years. And the volume of ischemia that we see on said stress tests has also decreased from 30% of the myocardium 20 years ago, and now we only see ischemia in 5% on average of the myocardium. And this is harking back to that earlier slide where we've just hit coronary artery disease so effectively with our primary preventative therapies that we're seeing a dwindling prevalence. And this has downstream implications for what happens when people hit the cath lab. In fact, in this study of over 400,000 patients, 62% of the patients who reached the cath lab had no evidence of obstructive coronary artery disease despite going through this pathway. And I'm going to take a brief moment to have a little chat about the Coloteca Bridge. This is a tiny city in Honduras that's regularly hit by cyclones and typhoons. And every time this happens, their bridges are wiped out and they're stranded from the rest of the country. So in an act of philanthropy, the Japanese government stepped in and said, we're going to donate a bridge to the city to help you maintain connection with the mainland. And in the design for the bridge, the words indestructible were foolishly used, and the bridge was completed. And a month within the bridge being completed, it was announced Hurricane Mitch, a Force 5 hurricane, was due to hit Coloteca. You all know where this is going. Except it didn't. The bridge stood up to the Japanese promises. It stood. Unfortunately, the roads leading to the bridge and away from the bridge did not. And in fact, the hurricane was so severe the river has shifted 50 metres to the right. So we've got a beautiful bridge over land. And I feel this is what we're looking at with our modern coronary artery disease management. We've been so effective in our primary care and in our primary preventative cardiology practices that we've shifted the course of coronary artery disease imaging such that the old imaging and investigative paradigm perhaps is no longer relevant. So can CT coronary angiography fix this? So we know CT coronary angiography is incredibly effective for picking up the obstructive coronary artery disease that we go on to see in the invasive cath lab. And in this meta-analysis of almost 4 studies, we can see that the sensitivity for the detection of coronary artery disease is astronomical in CT, which is exactly what you want in a low prevalence population. And its specificity isn't too bad either. It's roughly on par with all our current functional strategies. And this has gone on to be tested in a randomized controlled trial now where patients who were on their way to being referred to the cath lab were randomized to either CT or going straight to the cath lab. And of those who got CT, only 23% went on for an invasive catheter angiography. And of these, only 25% had normal coronaries, so a significant reduction of that. Whereas those who went straight to the cath lab, almost 2/3 of them had completely normal coronaries. And if we compare this to other imaging modalities such as SPECT, stress echo, exercise and cardiac MRI, all of which result in a 55 to 60% prevalence of non-obstructive disease, this is a marked win for CT. But perhaps most importantly, the event rate of major adverse cardiovascular events between the two arms were no different. So CT is excellent at picking up stenosis, and as briefly mentioned before, this is very good for predicting downstream risk. And indeed, in the PROMISE trial, which compared CT coronary angiography with functional testing in 10,000 patients, we can see if you have a normal coronary angiogram, your outcome is excellent. And if you have a severely abnormal coronary angiogram, your risk of downstream events is tenfold. So a marked distinction between normal, mildly abnormal, moderately normal, and severely abnormal. But if we compare this to the functional testing, we can see there's no difference between normal and mildly abnormal. And that's because this picks up flow restriction. It's not telling us about all the plaque that's sitting there slowly building up in the blood vessels, but isn't quite enough to restrict blood flow. And therefore, as a result, the severely abnormal tests only have a 4-fold increased risk compared to the normal and mildly abnormal risk. But what does this stenosis actually mean for the patient other than downstream risk? Well, this is where things get a bit muddy, especially whenever we're trying to diagnose the patient. If the patient has no symptoms, 1 in 5 of them will have a positive CT coronary angiogram, and that's just because we've all slowly developing atherosclerosis in the background. And it's the same on invasive cath lab. 1 in 3 of them will have obstructive coronary artery disease, even though they're walking around without symptoms. If we compare this with typical angina, so good going central crushing chest pain radiating into your neck, brought on by exercise and relieved at rest, we only see a doubling of the prevalence of these, which means that probably 50% of those with typical angina and obstructive disease on their invasive angiogram or on their CT scan probably had that a month ago before they started developing symptoms. So how are we able to tell whether they've just got a bit of reflux and happen to have coronary artery disease, or whether this is truly coronary artery disease causing angina? And indeed, this has downstream consequences in terms of whenever we try to manage these patients. In this randomised controlled trial with follow-up out to 12 years, if you put in a stent to patients with stenosis, you had no improvement in your outcome compared to if you just put them on optimal medical therapy. What about if we do go back to ischemia? Can we improve upon this and start to look at the pressure drop across the stenosis? And the reason we do this is if we look at the concordance between the stenosis and FFR. Now, FFR is a measure of the pressure drop across a blood vessel, with a pressure drop of 20% indicative of flow restriction. But 1 in 5 patients with only a 30 to 50% stenosis will have a pressure drop, and 1 in 5 of patients who have a severe stenosis of more than 90% will not actually be restricting blood flow to the distal myocardium. And indeed, if we compare putting in stents based on this fractional flow reserve, you have much better outcomes than if you just bang them in based on stenosis. And this is useful because now, using standard CT scans, we can start to look at exactly the same measures of pressure flow. So taking the standard anatomical model of the CT coronary angiogram and extracting the blood vessels, extracting the aorta from it, building a 3D pattern, and then plugging in computational fluid dynamic models, which we've had for the best part of several decades, and we use it in the aeronautical industry as part of routine before the plane will ever leave the ground. We can then start to derive this FFR such that we can see whether the stenosis in the proximal LAD is flow restricting or not, and in this particular case we can see there's a 30% pressure drop across this stenosis, and all of this is done without having to subject the patient to adenosine or exercise or stress. This is just them turning up, lying on the CT scanner, getting off 5 minutes later and going home. And we now have multiple studies showing this to be very accurate whenever compared with the invasive gold standard, with accuracies of 86% for picking up the presence of a flow-limiting lesion. And whenever we plug this into our standard CTA, we can see that it correctly reclassifies almost 70% of CT false positives to true negatives. But how does this compare to perhaps other modalities such as stress echo and stress MRI, or even PET scans in terms of picking up these patients? Well, this is one of my favourite studies from the last year, and you can tell how riveting a life I lead, that I rank studies by how much I like them. But I have to take my hats off to the folks of the Netherlands for their hardiness, because in this particular study they got 200 people to sign up to it. And on day one, they came in, they got their CT scan. They then got a PET scan where they got administered adenosine, and then they had a SPECT scan during which they got administered adenosine, and then they came back a day later to undergo an invasive catheter angiogram with yet another dose of adenosine. And I don't know if any of you have yet been unfortunate enough to have adenosine, but I was taught SPECT here by John Davidson, who had one as part of a research study, and he said by the end of it he knew what death felt like. So these people signed up for 3 doses of death over 2 days and fought through, and actually came back on day 2 knowing they were going to get more of the same. So hats off to them. And what did this do? Well, when comparing, instead of the accuracy that we're looking at whenever we're comparing stenosis with stenosis, whenever we look at the accuracy of CT for picking up this flow limitation on its own, that it's markedly less sensitive than, less specific than PET scanning and SPECT scanning, although continues to be much more sensitive. However, at about day 189, they decided, well, we've got all these CT scans, we've got this new technology, why don't we send them off for this computational fluid dynamic analysis? And that was exactly what they did. And now, whenever we compare the different modalities, with the blue line being the CT-FFR, red being the current gold standard of SPECT, or the non-invasive, gold standard, and then SPECT, we can see that CT-FFR outperforms all of these in its diagnostic accuracy for picking up flow-limiting lesions. But once again, I ask, what does this mean for the patient? And we have the same problem. 1 in 6 patients coming in with positive stress tests, with no symptoms, will have a positive stress test, compared to 1 in 3 who will have it with typical angina, which means, once again, 1 in 3 of the patients who have a positive test and typical chest pain probably had it several months ago, before the chest pain came on. And whenever we started putting in stents based on this invasive FFR and compared it to just optimal medical therapy rather than stenting based on stenosis, once again we see no difference in the arms. Now, this may sound all terribly doom and gloom, and are we looking at yet another Coloteca bridge with revascularization instead of diagnostic imaging? And I'm more optimistic than that, and I'll tell you why. If we look at both the stenosis-based guided therapy and the functional guided therapy, the two arms are arm in arm with one another. However, we know that stents cause a 1% event rate for every year that they're in place, and that's just because it's metal in a blood vessel. And yet these two arms are exactly the same, which suggests that the stents are having benefit. It's just being counterbalanced by the harm of the stent. So we just need to be able to better identify the patients that go on to receive revascularization, to pick out the ones that are gaining the benefit and separate off those that would be best with just optimal medical therapy. And perhaps we can do this with high-risk plaque combined with stenosis and ischemia, rather than just considering each of these in its isolation. And indeed, in the FAME study, whenever we looked at outcomes stratified by the presence of stenosis and ischemia, those who have both ischemia and stenosis have a markedly worse outcome than those who don't. And in this admittedly observational study, where they took 72 patients who'd had an acute coronary syndrome and had had a CT within 2 years before their acute coronary syndrome, and compared the culprit lesion that went on to cause the MI with the lesions that went on without events, we can see that for predicting which lesions would cause MI, stenosis is okay. Combination of that with high-risk plaque is better, and combination of that with ischemia is better yet. So we might be starting to see a state where we can actually identify those who are at the highest risk. Hippocrates is looking away from me in disgust at this point, because he knows I'm just inferring rather than proving, and I've not yet diagnosed the present. And this is where the Scott Hart study comes in, and this is a study for which Dundee was one of the performing centres, where we took 2,000 patients and randomised to either your standard workup pathway or a workup pathway with CT. And at 3 years follow-up, we can see that the CT significantly improved the number of patients who went on to have aspirin, and significantly improved the numbers who went on to be put on statins. It didn't significantly increase the number of patients who went on for invasive coronary angiography, but it markedly increased the rates of revascularization. And this could be seen as a good or a bad thing, depending on whether you think the stents are doing people any good. And in fact, it came under a lot of criticism, because on the primary outcome at 2 years, the P was 0.053 for the difference in mortality between the groups. You can imagine how popular the statistician was whenever they came back with this result. Which then led to people to say there's no difference between the two arms, therefore all these revascularizations are entirely unnecessary. However, whenever we follow these patients out to 5 years, give those statins and those aspirins a bit more time to act, and in fact, let all those patients who didn't receive stenting under the standard arm to eventually come back with their MIs and eventually get their stents, albeit delayed by 3 to 4 years, we can suddenly start to see that there is a substantial difference in the rates of major adverse cardiovascular events driven in the CT arm. And this has subsequently been verified in a Danish registry, where they found that what they observed in their real-world population was the exact same reduction of MIs, the exact same increase in revascularizations and primary preventative therapies in patients who were treated with CT rather than stress testing. This has resulted in the NICE guidelines being updated so that CT is now first test of choice for people presenting with chest pain. And this is some work I'm doing in England at the moment using national acquired data, and we can see that these guidelines have resulted in a huge upswing in the use of CTs and a huge downswing in those who are getting SPECT scans, and also a large reduction in patients getting invasive catheter angiography, in keeping with lots of these patients being deferred, no longer needing to go to the cath lab, who'd have gone there just to confirm that there was coronary artery disease or not. The next step will be to find out what impact this is having on mortality, of course. So, to conclude, whenever we're considering atherosclerosis, we consider it both as the general overall disease that's slowly progressing in all of us, that we can target and treat before it becomes symptomatic, but also once it does become symptomatic, that we can start to stratify further, more invasive strategies to treat and manage. And to look at all of these, we could either do an invasive intravascular ultrasound scan, an invasive coronary angiogram, introduce a pressure wire to measure the fractional flow reserve, and then do an MRI on the side to look at the plaque. Or we could just do a CT and get every single one of those measures at the same time. And CT really is potentially the Swiss Army knife of coronary artery disease imaging, where we can quantify the plaque, we can get our flow resistance. We're starting to now look at endothelial shear stress on this. And even more excitingly, we're starting to put in artificial or simulated stents within the CT scan and seeing how that impacts patient management. So that if you've got two stenosis, one proximally, one distally, do you need two stents, one here to improve the blood flow to the distal myocardium? Or could we just put a single one in at B or a single one in at A and get the same effects? And especially whenever we're saying these stents are associated with a 1% event rate per year, every year after they're in, if we can reduce by 50% the number of stents going in, this can only be a good thing. And this has been looked at in one study so far, looking at the accuracy of this, and it found that the simulated stenting better predicted the pressures after the stent was put in than standard invasive measures performed before the stent went in. So finally, Hippocrates is happy. I've shown that CT can declare the past by ruling out coronary artery disease. It can diagnose the present, improving outcomes through increased targeting of preventative therapies and improved stenting of patients who need it. And through the combination of high-risk plaque, stenosis and ischemia, we can identify those who are at risk of MI. And finally, we may be able to start to plan downstream revascularization strategies. So with that, I say thank you very much, and any questions?
Thanks very much indeed, Jonathan. That was a really remarkable capture of the complexities of imaging and how it relates to quite a complex clinical field. Any particular questions for the audience? Yeah, Ian. Got a list.
So you demonstrated that the incidence of myocardial ischemia on various forms of testing reduced over the last decade or two.
Yeah.
Does that, now, I'm not aware of any dramatic reduction in the rates of people dropping dead of heart attacks over that time period. Maybe there is, and please tell me if there is, but might it reflect just more people getting tests? And the overall number, the denominator, the overall number of tests being performed?
There's undoubtedly a part of that. On one of the early slides, we did highlight there was a 75% reduction in cardiovascular death over the last 4 decades. Yeah, it's impressive. It's in fact just this year past, it's cardiovascular disease as a whole has been finally overtaken by cancer as the number one cause of death in the UK. And that is because of these marked improvements in primary preventative therapies, I think, more than the revascularization strategies. But in that time frame of those 20 years from that particular study, they actually found that the number of procedures peaked about 5 years into that 20-year period and then slowly dwindled over the subsequent years. But I still think we are imaging people with lower and lower risk, although part of that is based on the calculations, because again, over that same 20-year period in that study, the pre-test probability of both cardiovascular death and coronary artery disease actually went up 25% over the same study period. So we are perhaps over-imaging, but we're over-imaging based on these calculations that are saying there's a huge risk of cardiovascular disease for this patient and saying they need further workup, but we're yet to adjust our calculations adequately for the sort of the brave new world that we're currently in.
Another observation. So 100 years ago, in fact, for the whole of human history, up to about 100 years ago, in the Western world at any rate, in the developed world, the diseases of poverty, or the disease of not having enough food, having to work too hard, and not having shelter, and now we've got the opposite. You showed us calcification in the ancients.
Yeah.
Those are the very rich ancients that you were showing. I don't know what the rate of coronary artery calcification would be in the other 99.999% of the Egyptian population 5,000 years ago. Do you have any idea?
You sound like a reviewer for the JACC Cardiovascular Imaging where that article was published, because that was exactly what they said in the editorial. We were looking at the most obese and sedentary of the Egyptian folk. And to give them credit, the authors of that paper went, that's a great point, let's test that. And throughout the US and South America, there's a variety of tribes that live at high altitude who don't have the same rates of obesity and sedentarianism, and have undergone a natural embalming because of the dry, cold weather. So they looked at all the mummified bodies from there who were just discovered incidentally in caves, and exactly the same feature was found of increased prevalence of coronary vascular disease within them. The one counterpoint to that, and in fact I hid the slide because in fact I got through, I thought my talk was already too long at 81 slides, but we flew through that. But if we pull this one up here, and this is one that really puts the cat amongst the pigeons, and really makes us also question what was going on in those mummified populations at the heights of the Andes, etc. This is the Tsimane tribe in the Amazon rainforest, who have managed to maintain a nomadic life even in the modern rainforest. They're dwindling further in number, but they hacked their way through the forest with a CT scanner in a big lorry. Good old imperialism. Well done on maintaining your indigenous life. Here's a CT scanner. But what they found was this is data from the States, such that whenever you're hitting 75 to 84, 50% of your population have masses of coronary artery calcium. Whereas whenever they looked at the Tsimane population, only the top 10% of those over 75 had any evidence of coronary atherosclerosis, which really does start to make us question, is it truly as inevitable as we feel? And one personal thought of why we might be seeing these differences is if we consider the populations living in Alaska and within the Andes, it's so cold that everyone has fires, and they're all having fires in igloos or caves. So in fact, they're sitting in a population with very high particulate matter, which we also know incites cardiovascular disease. So these studies may actually have just been showing that if you sit in a room with a fire for 40 years and then die, that you develop cardiovascular disease. But this population has caused problems as well in multiple other aspects, because another thing that's sort of a common concept in cardiovascular disease in the West is that it's all about inflammation, whereas this population had a very high sensitivity CRP, suggesting a very high sort of baseline low-grade inflammatory condition, which again should suggest that they all get cardiovascular disease, and yet none of them have. And we're now starting to try to figure out where the inflammation pathway therefore comes in, because it's undoubtedly causative, but there has to be another co-occurring factor that leads to this. And some are proposing that this population, because they're so active eating very well, they actually have very low density lipoproteins. So it could be that you need a certain level of cholesterol in your blood circulation for the inflammation to then start pushing that through the arterial walls. That's yet to be proven in any form of prospective study yet, but it's definitely the sort of hypotheses that are being generated based on this data.
Why do you think this population have a high CRP?
Low-grade helminthic infection from
immunological challenge of it.
Yes, yeah, exactly. There is TB amongst them, but it's predominantly parasites that are the driver for this, and they do all have large loads of parasites in their feces. Not all of them, but a substantial portion of the population.
Maybe the parasites eat the cholesterol.
It's certainly preventing them gaining too much weight. I look forward to a trial to reduce peripheral vascular disease through helminthic infection.
We'll sign you up as a PI on that one. Try the ethics for that. Helminthic infestation. Any other questions for the audience? We've had a pretty good romp through things. It just really goes for me to say thank you very much indeed to Jonathan for coming back. I think that was one of these talks where you actually sit and listen all the way through, and you're carried forward on a wave of optimism and also credibility and accuracy in the way it's presented, and I really commend you for that. Lastly, there isn't any plaque or bowl to give you as the eponymous lecturer, but I'll give you one of mine that I was given for the Scottish Radiological Society, who managed to produce 2 plaques and bowls for me for the last time I gave a talk, so I've got a spare one you can have. That's okay. So thanks very much indeed. Thanks, Rich.
Thank you.